they go home and they resume their fast food restaurant status every day, going out, let's go to Taco Cabana today, and tomorrow we're going to McDonald's. See, it all depends. We got to have buy-in, right? Buy-in. We got to influence them so that they can understand that. So why do people fail to follow regimes? And that's maybe they don't understand that smoking 3 packs of cigarettes a day is going to lead to something. See? Or maybe they do, but I just use that. Maybe they really didn't. Or eating that one too many Big Macs, right? Cultural objectives. Maybe there's something that within their own cultural influences that might cause them not to follow something. Or their lifestyle may make it difficult. Some people have such a high stress lifestyle. They're Wall Street stock broker. And in this day and age, it's probably quite stressful, right? They can't even, they come in there, they've had a myocardial infarction, a heart attack. And as that nitroglycerin's dripping, they got the IV nitroglycerin going in for the chest pain. They've got their laptop out trying to do buys and sales, right? See, they're going to have to reconsider. But they won't, That's where the money's at, and that's what drives them, see. So sometimes it's difficult to do that switch. That's true. So, best results, nurses need to have interpersonal skills to succeed in nursing. You need to assess the client's knowledge and their support resources. Be sensitive, always cultural sensitivity. Accept some of those attitudes that cannot be changed. What is the client's main concerns? And then help the client set their realistic goals, and then you're talking openly and importance of the adherence to whatever's being followed. Again, I think I have beat this horse to death. The delegation, right? Know what you can delegate. Remember, you're the responsible one. You can delegate the CNA to turn the patient, but the CNA is not going to do that skin assessment, the breakdown on the backside. That's your responsibility. In your textbook talks about these delegating tasks, right task, activity, and this is just, you can find this in your textbook. Is it within the scope? LVN or CNA, whatever. Within the policy, the institutional policy, that you can delegate this certain task. Task you can delegate. And don't forget, an ICU nurse will be the CNA, the LVN, the unit secretary. They will be all of those things. I will be all those things. That's what I am, because I don't have these things. So you may still, may not be no delegation going on, depending on wherever you work. You may be it. So just remember that. But you've really you're learning a lot, learning everybody's. And certainly this weekend, I had that group, and they had these roles, and I make them draw out of. I put them in I fold up a little piece of paper, and I let them draw. Team leader. And then I take that one out, and I have blank sheet, and the med nurses, let them draw. Wound care / CNA, let them draw. Who's going to get what? And CNA. And they definitely have a total respect of what the role of that CNA, how hard they have to work. That's why I love the little game I play, and it's the last quarter. But it's fun. It's hard work, though. And they do have respect for what that CNA has to do day in, day out. Okay, tasks you can delegate. Bathing, ambulating, obtaining vital signs. You'll give them specific directions. Take Mr. Moore's temperature every 4 hours and notify me if the temperature is greater than 101. That's a clear direction for that CNA, right? changing linens. But remember, all these you guys will do when you go to the nursing home. You guys will do these because I want everyone to feel, they need to feel what it's, all the responsibilities, all of the tasks. You need to be able to do whatever you're making your subordinates do. You should be able to do those same tasks. You cannot delegate the responsibility for total patient care. That's your job, RN, total patient care. You are responsible. You can't have another nursing assistant personnel delegate to another one. You see what I mean? You're not going to be, you can't allow that to go on. That's not, you can't allow that. You might see it, that's not correct. Right circumstance. Before deciding to delegate, assess the patient, be sure that patient needs match the abilities there that they have within their scope of practice to do. A very ill client that's unpredictable, that task should not be delegated. That should be your responsibility. And I give you an example of an ICU intubated patient that's got about 5 drips going on up there. There's your illustration. You're not going to delegate that. You're going to take care of that patient. That's your patient. That's your baby. See? Right person. Again, talking about making sure that they're competent and also their workload. If they're already overtasked, don't give them more to do because something's going to get dropped. There's going to be a ball that gets dropped there. And then communicate clearly. And again, I went back to that example. That's a clear example of a communication to a CNA. They know exactly what they're supposed to do. Every 4 hours, if that temperature is greater than 101, they're going to tell me. Right supervision, because you're always supervising. If you're delegating, you're in charge. You're responsible. It falls back on you. It will come back on you. And then finally, the final step is implementation. Is charting. Chart what you do. Take credit for what you do. Do not walk away after you've had a hard day and fail to chart. So I did an example for you. Assisted up in bed. Notice I didn't put Mr. Moore in there, did I? Assisted up in bed. They're bulleted kind of statements. You see phrases. Assisted up out of bed. That's OOB. Ambulated 20 feet. It's very objective. 20 feet with assist of 1 staff. Gait unsteady. That's Mr. Moore's gait. Could be the nurse, but I'm talking about Mr. Moore. Voided 250 milliliters of clear amber urine. I described it. It's measurable. I could put that on the IMO sheet, couldn't I? Assisted back to bed, and I remind the gatekeeper back to bed. Gait's unsteady. I'm talking about safety. I sign it. See how we did this, y'all, in my Tuesday group, remember? There's your nursing note. Right? Nursing note. And here's a good YouTube. It makes you think. We'll have to turn volume on. You need to listen to this. This is serious business here. This is what gets your license for.
Good morning. What I'm going to be talking about this morning is documentation and how the chart is used in the process of litigation. I'm also going to cover with you the reasons why patients or plaintiffs go seek out plaintiff attorneys to file litigation, and some of the factors that contribute to errors. We're going to focus a little bit on miscommunication and on delay in treatment. And then finally, I will wrap up with talking a little bit about computer order entry and give you some case studies that emphasize the importance of having clear and legible orders. The most common reason that plaintiff attorneys are contacted by patients or their families when there's a bad medical outcome is they want to know what happened. They can't figure it out. They've asked for an explanation. Maybe they didn't understand the explanation. Maybe they didn't get an explanation. They're looking for answers. And they believe that by contacting a plaintiff attorney and having somebody look at their records, they will find out what happened. At that time, the resident was told by the nurse and by the mother of the patient who was at the bedside, that her daughter did not tolerate opiates well, but she had received Toradol in the past and had gotten a good response from that. The resident's response to the nurse and to the family was, "I'm the doctor, I know what I'm doing," and she left the Demerol order as is. What was key in this case was that there was an assessment form that was supposed to be completed by the nurses. They were supposed to evaluate level of consciousness. And you can see that it was done at 12:40, but there is no subsequent documentation of level of consciousness. When the patient had her arrest, there was a blood level drawn, and they found toxic levels of Demerol in her blood, to the point that it caused this patient to have a respiratory arrest, to be put on a ventilator, and then life support was withdrawn 4 days later. For example, it may happen like this. The nurses who work in the labor and delivery area have concern about changes on the fetal monitoring, but they were, in this particular case that I'm referring to, which was a North Carolina case, they were reluctant to talk to the obstetrician because he had a response that was typically negative when nurses approached him about concerns about a patient. So they did not approach the physician, and there was a bad outcome with the infant, and there was a $1.2 million settlement. A study that was done by the Institute for Safe Medication Practices focused in on how frequently this is occurring and discovered that when about 2,000 healthcare providers were surveyed, that the problem was much more pervasive than they realized, with the majority of people saying that they had not clarified orders for medications, for example, because they were intimidated by the response that they were likely to receive from a particular provider. I'll give you an example. I've reviewed several cases of people who have fallen out of Hoyer lifts when nursing assistants were moving them. As they're swinging through the air, they get dropped onto the floor, usually resulting in a fractured hip or a subdural hematoma. Nursing assistants in at least several of the cases were afraid that they would get in trouble by saying what happened. So they did not report the incident. The nurse who was evaluating the patient detects that the patient's complaining of leg pain, the leg is externally rotated, it's shortened, it's causing all kinds of concerns about what happened here, but the medical record has no information about it. So in that instance, the plaintiff attorney could assert that there was a cover-up of the original injury. An interesting note that I once found in a nursing home record was an entry that said, "Please leave for 3 to 11 shift enough room for documenting the fall when they rewrite the nursing notes." That's considered tampering with records, and in that case, the suit was resolved even before it got filed. This is an order for cisplatin, and this was a case involving a 9-month-old infant who was supposed to receive 20.4 milligrams.
See the importance
Got
of the
204.
decimal.
When the order was transcribed, the decimal
0
disappeared.
point.
When the order went down to the pharmacy, there was a warning on the cisplatin that recommended double-checking any dosage that would be in this level. 2 people checked the order but didn't pick this up and supplied it to the nursing unit. The child received the chemotherapy and died 2 days later, and when the autopsy was done, they found toxic levels of cisplatin in his blood.
It was important to us at our hospital to have our clinical staff educated regarding the impact of their documentation to future potential litigation. We asked Pat to come and address our staff on her experiences as a legal nurse consultant and basically give us some insight into how our documentation can protect the healthcare provider and the hospital in the future. We found the presentation very helpful. We had 2 sessions. We had counted 108 people in attendance, which is a remarkable feat for getting people to attend in services within the hospital.
Usually, any in-service on documentation, you get good follow-up, good attendance, because we all can use more in-service on documentation. Final step, evaluation, it's a plan ongoing systematic activity, and that sort of helps you know, are we on track? Are we tracking? Is the patient tracking to achieve the goal that we have established? Evaluation begins as soon as you've completed that first nursing activity. You're assessing to see. And here's some examples. You just received orders. It's a nasal gastric tube. It'd be a tube that goes down to the stomach and it can drain gastric contents. I don't know, maybe they've had some sort of surgery or whatever. So you go back and you remove, or you go in there and you remove the tube, and then you're going to do follow-up. Make sure that they don't walk in there and they've aspirated. Because why would you have the tube in there? It's you're draining gastric contents. Or perhaps their stomach gets distended again. They're feeling nauseated again. Maybe we have to do a reevaluation, reassess. Maybe it's too early to pull the tube, right? The same thing goes with the endotracheal tube. You do a series of weaning down on the ventilator, and then you remove the endotracheal tube, that hard tube that goes down to their lungs. One of the worst things that can happen, and I've seen it happen, is a patient's tracheal, the tissue after removal, it begins to swell. One of the worst things that can happen. I actually had a patient pulmonologist extubated him, and he moved on down to the 6th floor, the SI, we were on 7th. And I had to call him back, so you got to get back up here. I'm hearing these crowing sounds, and I feel that her trachea is going to get blocked. He gets back up there. He initially had a size 7 endotracheal tube in, and he was barely able to get a 6, a pediatric 6, and that's a lot smaller tube. And you could hear as he's passing that back through the vocal cords, you could hear it scraping the prime cord. I mean, it's the eeriest feeling, but he got it in. But I guarantee, so he was very cautious in extubating her. It wasn't that she wasn't ready for extubation. She had sort of like a inflammation flare-up post the pull of the tube. So he made sure that prior to the extubation of that size 6, that he definitely had her on Decrodon as a steroid to make sure that inflammation wouldn't flare up there. So, but those kinds of things happen. And you don't know when things are going to happen, but it's because you go back in and you do those assessments, you see. Those follow-up assessments. And in that case, that was, I was watching her pretty constant. Anyway, you would do that with a post-extubation anyway. Yeah.
At that point, he hadn't had overdose.
Oh, it'd been, well, I knew where he was at. I knew where the doctor was. I knew he was in the SI. Because he, telling me that, he's going to be down the SI, so I knew where he was, but in the event that he would have come in extubated and left the hospital, I would have called Code Blue. I wouldn't have waited. I would not have waited for her to stop breathing on me. I would have been proactive, because if that was your mom, wouldn't you want the nurse to be proactive and call Code Blue? Let's stop what's happening.
Right, so you couldn't get it yourself?
No, I can't. We're not certified to do that. No. Even if we take ACLS, which I am ACLS certified, within the hospital confines, I am not authorized to intubate. It has to be certified person. Some respiratory therapists within the hospital systems, I think the BAMSI or SAMSI, you want to call it, they are authorized. I think probably university system, they are authorized, but no, it has to be the doctor. Like I work in the Baptist system, the doctor has to reintubate. So I would have called the ER. I would have called, I would have called Code Blue is what I would have done, because that happens the fast. I'm not going to wait for that patient to stop breathing, because I already know, when I hear crowing sounds, I know that that airway's narrowing, see? My assessment. You could hear it like that. You know what's happening. It sounds like sort of like and you hear that with children, pediatric epiglottitis. And I don't even teach meetings, but you'll remember epicontitis, we had that little situation. That's an interesting one. You'll learn. Intermittent evaluations, you're following up 1 hour after a pain medication is being administered. It is the law in any facility. You give a pain medication, you follow up 1 hour. See, because Meredith's fifth vital sign, right? We have to act on it. Terminal evaluations, that's how you progress toward like discharge, at the time of discharge. Looking at revising the plan. You might have to, after reevaluate, you might have to revise the whole plan. This thing did not work at all. We therefore have to go back and revise the care plan. Yes, the RN will have to do that. It just didn't work. That's why we're doing evaluation. We're always assessing. We're always looking, because you want the maximum result. You want to do it within the shortest time. You want them to recover as fast as possible. So if you see this plan's not working, why continue along that path? It doesn't make sense, does it? You see what I'm saying, right? Quality assurance, and you'll have these risk management, well, they don't have risk management, they call it quality assurance, where they're doing follow-up care and making sure that what we're doing is right in tune with what we should be doing. QA, the term QA, QI, they have all these different terms, these acronyms. They use different terms, but it's all making sure we have good quality care provided to our patients. And now we're at the time we take a 10-minute break, and as you can see, we're still on doing our critical thinking with working with the Garcias. So I ask that y'all break up into your think tank groups. You like my thinking cap person. Every time, I'm always having y'all do that, because I want you to use your volume 2 and use your CD. In these group discussions, again, there's no right or wrong answer. I'm getting you guys to learn how to talk and discuss. So I'll leave that up for y'all to